This talk is on CKD and epidemiology. And what we'll try to do is to gain insight into the epidemiology of CKD in developed countries and in emerging countries, and look at the causes of the underlying rising incidence of CKD. But I also want to make a distinction between community CKD and referred CKD, as well as the clear distinction between the causes and the epidemiology of CKD in emerging countries from the causes and epidemiology of chronic kidney disease, CKD, in developed Western countries. So if we start CKD in the West, community CKD, small c CKD. And you're all familiar with this bubble that's been blown and blown and blown over the last 10 years of the prevalence of CKD in Western countries, going up from 5, 10, 15, 16% within the community. So that's community CKD. That's the work of epidemiologists and to a lesser extent of that of nephrologists. And we need to be careful about this overestimation of CKD, and we'll see why. If we look at all the study, there's an interesting review and systematic analysis. And systematic analysis are very important because they bring together all the data and analyze it carefully and look at issues not in a single study, and the first thing they do, they call it IKF, impaired kidney function, because you'll see later on that most of these studies are single cross-sectional epidemiology studies. So you can't really say whether it's acute kidney injury, whether it's impaired kidney function, or whether it's chronic kidney disease. And these are all the studies, or many of the studies on the prevalence of impaired kidney function of CKD, and I recommend that you read this article very carefully. And you can see that the prevalence varies from 45% in some studies, like that of Iseki in Japan, to as little as 2%. So the prevalence varies widely. And the interesting thing on this slide and in that paper is that they've ranked the quality of these studies. So the high quality studies are the histograms or the bars in gray, and you can see that the great majority of the studies claiming 40%, claiming 35%, claiming 25% are of low quality compared to a few of high quality, and we'll carry on with this theme. So first, this slide tells you that the prevalence varies an awful lot from study to study, from as little as 2% to as much as 45%. And obviously age will be a factor. So if we summarize all these studies, we can say that the prevalence of CKD varies, but on average it's around 10 to 15%. To a large extent due to the fact that microalbuminuria in the community is around 7%. Low estimated GFR in the community as a whole is around 3 to 5%, but obviously if you look at your talk on CKD and aging, you'll see that in the older age group it can be as high as 40%. And interestingly, when you start going down to GFR less than 30% or 30 ml per minute, you get rates of 0.3 or 0.4%, and when you go to CKD stage 5, within the community it's less than 0.1%. So obviously CKD 3 is a very large group, and then it fizzles out, and throughout your NOC you'll understand why. The first thing to concern us about epidemiology of CKD is there are issues with CKD screening program. These are conducted by epidemiologists and seldom by nephrologists, or driven by epidemiologists as well as nephrologists, but they have major flaws. So before we take the data on board and before we accept it, and in the spirit of the NOC, we need the 5 whats. We need to think of why these studies were done, the validity and the quality of these studies, the relevance and the utility of these studies, are they cost effective, and is there a risk benefit in labeling people as CKD. But the major flaws are as follows. Most, if not all, these studies, whenever they screened for microalbuminuria, they equated a single positive test for microalbuminuria to chronic kidney disease. And that's obviously wrong. They've equated a single positive test for microscopic hematuria, in other words, a dipstick showing 1+ hematuria, never mind 2+, never mind 3+, just 1+, as CKD. They've tested once, and I'll show you some evidence for that. They've used for EGFR the MDRD formula or serum creatinine derivation formula that are not applicable to the general population. The MDRD equation is derived from the modification of diet in renal disease randomized controlled trial published in 1993, and it was in a patient population with advanced CKD, CKD 3B and CKD 4, for which the formula was designed and calculated, but not for CKD 1 and 2, and not for general population consumption and purpose. And finally, you'll see in the CKD and aging talk that the majority of people with CKD are over the age of 60. If you look at under 50, less than 2%. If you look at over 50, you get anywhere between 20 and 30%, and over 70 to 80 you can get up to 40%. So all this, including the single screening, and very often upon repeated screening albuminuria disappears, 1+ hematuria is no longer there, EGFR is variable, can go up and down, as the serum creatinine measurement is also very variable, and the EGFR formula are at best imprecise with large variability. So all this led to overestimation of CKD, and all this led to this bubble of epidemic of CKD being overinflated. And this needs to be addressed, and this needs to be revised, and some sense need to be put into that. And again, this is where you, as young pioneers in CKD, and the NOC, and the critical thinking and the reflective thinking will start a more critical look at the so-called epidemic of CKD. Let's go back to the McCullough paper, and again here it shows you the summary of the prevalence of CKD in the high quality studies. So now he's identified few high quality studies, less than 10, and in the so-called high quality studies that he found worth defining, he notes that most of them have single sample estimation. So 1, 2, 3, 4, actually all of them have single sample with the exception of the Stevens that had 2 samples. So you can't really say chronic kidney disease. That's why once more he calls them impaired kidney function. And then when he used the so-called high quality and apply a quality criteria, fully achieved is the open circle, not achieved is the full circle, you find that every one of them has a major flaw. The Stevens one was a primary care GP referred population, poorly representative, therefore there's a sampling bias and a sampling poor quality criteria. If you look at that, the John study in the UK again, there's an assay bias. But mostly all of the ones done in Europe, the Chen one in Taiwan, in China, Norway, United States, in all of these only tested once, only establish impaired kidney function but not chronicity, and therefore cannot be reliably accounted for as numbers of prevalence of chronic kidney disease, because cross-sectional studies does not make chronicity. You need 3 months, you need repeated testing. So let's look at community CKD in the West. We have to conclude that based on the studies and based on the quality of the studies and basically the single testing nature and the cross-sectional nature of all these studies, we don't really know, and certainly there is a major risk of overinflation, especially when we mix poor quality as well as including in these studies prevalence, the fact that older people have impaired kidney function and labeling them as chronic kidney disease. So there's an issue with definition, there's an issue with the classification, there's an issue with screening, and obviously there is an issue with epidemiology. So the prevalence is really unknown. Let's look at the causes. If you look at the human burden of disease over the centuries, 3-4 centuries ago, we were in, and even before, we were in stage 1, the stage of diseases, infections, famines that killed millions and millions of people. Then life expectancy improved and we lived a bit longer, more than 40 years, the stage 2, that of receding epidemics. So, the flu epidemic, the malnutrition epidemics, the TB epidemics, the plague epidemics, all these were receding, and the degenerative disease started to appear, hypertension, diabetes, and so on, which is the stage 3, and people lived longer to get to the stage of degenerative disease and man-made disease, globalization, smoking, high-fat diet, obesity, and so on. And now, in the West, we're in the stage of even delayed degenerative disease. So life expectancy is over 70, population is aging, as you will see in your CKD and aging talk, and therefore age-related conditions, you can call them disease, are increasingly apparent. With them, cardiovascular disease, and with them, chronic kidney insufficiency. You can call it disease if you wish. And that's what I've shown you over and over again in many of the NOC talks. Prevalence of CKD in the USA under the age of 60, hardly detectable in the community. Over the age of 60, more than 30%. Over the age of 70, almost 40%. And in the USA, if you look at the causes, first you'll notice that all CKD increase with age again, over 60 years of age, more than 32%. Most CKD epidemiology studies based on EGFR formula show a higher prevalence in women compared to men, but this is probably an artifact of the MDRD formula, which is less obvious with the CKD epi formula. Prevalence in whites and African American, fairly comparable in that particular study and survey. Diabetes, a large percentage of individuals with diabetes, a large percentage of individuals with hypertension, but look at that towards the bottom, 25% with cardiovascular disease, known cardiovascular disease in the 80s and 90s, and now almost half the population has known cardiovascular disease. And you'll see in your CKD and aging talk that cardiovascular disease means or equates chronic kidney disease, because in the community the major cause of chronic kidney disease is aging and vascular aging. If you look at the percentage of the population with microalbuminuria and albumin creatinine ratio to the right of your slide of more than 30 milligram per gram, again the prevalence and the incidence of microalbuminuria increases with age and has somewhat increased recently, and the same apply to decreased EGFR, which obviously is hardly present in people decreased EGFR less than 60, hardly present under the age of 40, slightly more up to 60, but then we get in the much higher range of GFR less than 60 in older people, and you'll see in your CKD and aging talk that this is age-related physiology or age-related pathophysiology, but certainly not a disease. Back to the McCullough. Again, if you look at age, for any one of these studies, hardly anybody with CKD under the age of 40, few up to 59, but the majority up to over 40% in some studies in the over 60, 70, and 75. So CKD in the West is a condition, I put disease between brackets, of older people. Older people have impaired kidney function. Older people, as you know, have higher albuminuria. And if we screen them, we find these abnormalities, age-related abnormalities, and we can call them CKD. But they're not a disease. And we'll look at the outcome later on. So I called it cardio-kidney damage rather than disease. Life course exposure to hypertension and diabetes. Metabolic abnormalities, obesity and dyslipidemia, toxin, smoking and NSAID and analgesics, leading to vascular damage, leading to atherosclerosis with arterial stiffness and endothelial dysfunction, leading to microalbuminuria, renal ischemia, coronary artery disease, cerebrovascular ischemia, and macular and ocular degeneration. Now, can we predict who in the community, usually older people, will develop CKD or not? And again, I recommend this systematic analysis of Chugi and Knigny in 2012. And what the study showed is, in 2012, how to predict incident CKD in the population in general. And if you look at the number of studies, whether it's the SCORED study, the study of the Framingham score study, or the Sagar study that I'll come back to, they rely on cardiovascular parameter, age, gender, hypertension, diabetes, cardiovascular disease, heart failure, cardiovascular biomarker, C-reactive protein, cystatin C, homocysteine. All these tell us that people, as shown by Sagar in 2008, people with cardiovascular, underlying cardiovascular pathology, heart failure, peripheral vascular disease, cardiovascular disease, hypertension, diabetes, are at higher risk of developing with age CKD. More models here. Using albuminuria, using CRP, using brain natriuretic peptide, using leptin, using a lot of vascular predictors, and they all predict more or less incident CKD. So I go back to the fact that if you have underlying cardiovascular disease, if you have underlying comorbidities in the West and you're growing old, you're more likely at the age of 60, 70 or 80 of having impaired kidney function through renal vascular pathology, part of systemic cardiovascular disease. Now let's look at the East and look at emerging countries and look at again community CKD in emerging countries, and there we'll find a much more complex picture. So instead of just cardiovascular disease and aging, people don't live as long in emerging countries. People are poorer in emerging countries. People are still having the burden, not the growing burden of cardiovascular disease, but also the persistent high burden of chronic communicable disease, infections. And all these will impact on the incidence and the prevalence of chronic kidney disease. So in emerging countries, we may not be at stage 4 of delayed degenerative diseases and a life expectancy of over 70. We're between stage 2 with still some receding epidemics and pandemics such as HIV, TB, malaria, and some man-made degenerative disease due to globalization, change in diet, change in calorie intake, tobacco use, and increase in cardiovascular disease. Chronic communicable disease, malaria is still pandemic in many parts of the world. 300 million of world population is infected with malaria. Hepatitis, and mainly hepatitis C, 200 million. Schistosomiasis is still there, and the rising and the considerable burden of HIV, predominantly, as you can see from that map to the right of your slide, in Africa. All these are associated with acute kidney injury, leading to impaired residual kidney function, chronic kidney disease, but also associated with microalbuminuria, proteinuria, and progressive kidney disease. So if we look at prevalence of cardiovascular disease, which is the additional burden in emerging countries, which is brought about by globalization, change in lifestyle, westernization, on top of infections, on top of poverty, you find that, interestingly enough, that heart disease and cardiovascular disease have fallen considerably in major Western economies, Canada, UK, Australia, and the USA, since the 70s. Since improved blood pressure control, since improved diabetes control, since the advent of statin and attention to hypercholesterolemia and cessation of smoking. The opposite is true of emerging countries. Heart disease and cardiovascular disease are following the westernization and globalization trend in emerging economies and low and middle economies, and is on the increase. Take hypertension. 972 million individuals worldwide are hypertensive. This will increase to over 1.5 billion by 2025. And the increase will be dominant in places like China, like India, like Africa, where it will double in incidence and prevalence. And urbanization, if you take obesity, and I'll come to diabetes, if you look at poor and small rural areas and villages, very little obesity. But if you look at urban, middle-sized and large-sized cities, in pink you see the prevalence of obesity and overweight increasing. And along these lines, exactly the same. This is a Chinese example of prevalence of diabetes in rural villages, very low, less than 1%, looking at large cities like Beijing and Shanghai, exceeding 6% and sometimes 10 to 15%. And this is the global picture of diabetes, and to a large extent the rise of obesity and type 2 diabetes. Currently worldwide, about 154 million people with diabetes. By 2030, projected to double. And when you look, mainly projected to treble in developing and emerging countries, where the increase will be considerable. In Africa, 200% increase. In India, 250% increase. In China, 127% increase. Even in the United States, 100% increase over the 30 years from 2000 to 2030. So epidemic of diabetes, but also affecting emerging countries. And don't forget in low and middle economies and emerging countries, in the Middle East, in Africa, in the Far East, kidney stones are also a major problem. Up to 20 to 25% of patients with impaired kidney function in some countries have renal stone disease. Much less prevalent in the West, much more prevalent in emerging countries, and in particular the Middle East. Consumption of nephrotoxins, and including non-steroid anti-inflammatory agents. You can't get them anymore in a lot of European countries over the counter. You can't get them in Canada or some parts of the United States over the counter without a medical prescription. But you buy them freely in the Middle East, in North Africa, in Africa, and in Asian countries. And people abuse analgesics and abuse non-steroidal anti-inflammatory agents, and these contribute to a very large extent to the impaired kidney function of many people in emerging economies. Herbal toxicity and herbal nephropathy, now most commonly attributed to contamination of foodstuff by Aristolochia containing aristolochic acid, which is a nephrotoxin. This was first drawn to the attention perhaps in the Balkans, then in the Far East, now in Central America, with huge pockets of CKD epidemic, possibly linked to aristolochic acid and aristolochic acid related nephropathy. And you can buy traditional herbal remedies, or you can be given traditional herbal remedies in developing countries, in rural areas, by non-medical healers and village healers and so-called doctors who prescribe traditional herbal remedies containing nephrotoxins to a large number of people with all sorts of complaints. Chronic consumption of these will lead to impaired kidney function, and chronic consumption of these will lead to chronic kidney disease. And this may explain why, if you look at the incidence of ESRD, the highest in the world is in Asia, is in Taiwan, is in China, and this highest prevalence. And this has been linked to the consumption of herbal remedies and herbs such as mutong containing very high levels of aristolochic acid. And there are also additional risk factors affecting the incidence of chronic kidney disease in emerging countries, the possibility of pollution, heavy metals such as exposure to lead, climate change and impacting on communicable disease, natural disasters including earthquake causing acute kidney injury, and acute kidney injury is becoming recognized at least as a major cause of chronic kidney disease. Malnutrition, making people more susceptible to infections, and also low birth weight. Low birth weight in a lot of emerging countries and low and middle economies where poverty prevails has been described as one of the major causes of chronic non-communicable disease, such as obesity, such as type 2 diabetes, such as hypertension, and such as cardiovascular disease. So if an individual or a newborn is born with a weight below the expected for gestation or age, he or she is at risk of non-communicable diseases in his adolescence and adulthood, but also is at risk of chronic kidney disease. Low birth weight is associated with low nephron number. Low nephron number may be associated with large glomeruli and large nephrons. So we've got oligo, small, mega, large nephron, nephronia, oligo, mega, nephronia. and this may, through hyperperfusion and hyperfiltration of the glomeruli, lead in the long term to glomerular sclerosis, albuminuria, and chronic kidney disease. So low birth weight is something to pay more and more attention to as a predisposing factor for chronic kidney disease in emerging countries. And also other factors that are becoming more and more of concern relate to environmental pollution, including pesticide. And for instance, there's an epidemic of chronic kidney disease in Central America that has been linked to excessive incidence of chronic kidney disease in farm workers, sugarcane workers, cotton farm workers exposed to excessive heat, but also possibly excessive use and exposure to nephrotoxin such as pesticides. So in the emerging economy, CCKD is related to poverty, which impact and increase the risk of albuminuria, hypertension, diabetes, cardiovascular disease, and chronic kidney disease. Communicable diseases causing chronic but also acute kidney injury, which in turn turns into chronic. Westernization with hypertension, obesity, and diabetes, but also toxicity and low birth weight. Now, we've looked at community CKD, CCKD, in developing country, primarily problem with aging of the population and exposure to non-communicable disease and cardiovascular disease with age. In emerging countries, relating to poverty, infection, westernization, pollution and toxicity, and low birth weight. Now, if we look at referred CKD and its epidemiology, we get a completely different picture. So if we look at the West, you've got diabetes, but also you have glomerulonephritis. You have renovascular disease, which is linked to cardiovascular disease, but you also have pyelonephritis. You have hypertension, which is non-communicable disease, but you have polycystic kidney disease, and you have unknown etiology. So glomerulonephritis, pyelonephritis, polycystic kidney disease, all these are major causes of referred CKD. Referred CKD in the emerging countries, similar picture, but then acute kidney injury takes a much larger role in the AKI-CKD link, whereby infections, dehydration, diarrhea, cholera, malaria, TB, all of these cause acute kidney injury, which don't recover fully and constitute an increasing pool of people with impaired kidney function, chronic kidney disease. They may be stable, but they are living with impaired kidney function. And you also have the burden of interstitial nephropathies and renal stone disease. Interstitial nephropathies, as we saw, perhaps linked to pesticide, perhaps linked to pollution, perhaps linked to heavy metal exposure, including lead and others, and perhaps to a large extent in certain area, endemic area, linked to the excessive consumption of aristolochic acid. And this is the Indian example where again referred CKD to a large extent diabetes, but also glomerulonephritis, and also unknown. And very often the unknown can be related to interstitial nephritis, including tuberculosis. I think one of the problems in the epidemiology and the management of chronic kidney disease, referred CKD in emerging economies, is the late diagnosis and the late referral. I think the major problem there is with CKD in emerging countries, including the Middle East, including Africa, including Asia, and including North Africa, is the fact that the great majority of referred CKD are seen at stage 5, sometimes weeks, if not days, if not hours before they need renal replacement therapy and they've reached end-stage renal disease. 49%, 50% in India present in end-stage renal disease. Another 25 or 26% present in CKD stage 4. In other words, 75 or 76% of those presenting to nephrology attention in India in particular have advanced severe CKD and mostly ESRD. And that's not good enough. Instead of worrying about CKD stage 2 and CKD stage 2 in emerging country, a major focus has to be why only 10 or 19 or 20% of CKD 3, including CKD 3B, are referred to nephrology center, are accounted for in CKD registry, and are properly management. Because if we want to prevent ESRD and CKD related morbidity and mortality in emerging countries, we need to see these patients early, not at CKD 1 and 2, but during the large and long stage of CKD 3 and mostly CKD 3 with proteinuria and CKD 3B. So we've put here for you some recommended reading, and I recommend that you spend some time reading the large reviews, but also spend some time critically analyzing what is being said to you about CKD epidemiology. Look at, as we said, the definition of CKD and how it's applied, the research tool used to define the epidemiology, the critical appraisal of definition, classification, and research methodology, and a critical evaluation of the conclusion of published data on CKD epidemiology, and the reference of McCullough from Nephrology Dialysis and Transplantation in 2012 is an excellent one to look at and read. Now we would like you to do, in relation to CKD epidemiology, review this critical appraisal, describe the limitation of current CKD screening programs, be aware of screening recommendation, and we'll come back to CKD screening and the different recommendation in the CKD screening talk, but also back to reflective practice. What are the major risk factors of CKD that you see in your own practice, in your own community, that are relevant to you? Maybe low birth weight. It may be environmental pollution, and be precise and show evidence. It may be consumption of herbal remedies or excessive use of nephrotoxic agents such as non-steroidal anti-inflammatory agents. It may be infections translating to residually impaired kidney function after the acute kidney injury and CKD. And it may also be renal stone disease and westernization. So pay attention to your community. Look at epidemiology in your context, in your practice, to make your NOC more reflective and your learning more useful to your own work environment. You'll have the questions, 4 or 5, each related to CKD epidemiology, which will be made available to you and will test your knowledge of the subject. Thank you very much. End of the CKD epidemiology talk.